Now, what I want to do is not to screw things up. So I've got the pointer. I can advance and close. What about that bar there? It disappeared.
Try to get it out of the way.
Okay.
Sorry, I keep advancing.
Okay, very good. Well, it's good to be here. Anya, you trained in Wisconsin, you got my slides up, which is great. The last time I talked here was 2009. I was mentioning that to Steve last night, and at that time I talked about IL-5 and eosinophils, and this was before we had the anti-IL-5s there. So I think I've moved on a little bit. And what I want to talk about is asthma contributor to dementia. This is very sensitive. This is Madison, Wisconsin, and Capitol's here, universities down here, about a mile apart, a big mile, big government and the university, as you can imagine. So these are my disclosures. Shouldn't interfere with anything I'm going to be saying. So what I want to do is review the effects of psychological conditions on asthma, to discuss the consequences of it on asthma in relationship to a loss of brain health and also possibly contributions to dementia. Good morning, Teal. So consider asthma as I want you to consider asthma as a systemic disease and how treatment of asthma may actually diminish the loss of brain health. And really, as I'm going through here, if you've got questions, ask me, because you may, if I were asking a question, I may not remember it at the end of the talk. So anyway, and so introduction. I think Len maybe is the only other one in the room here that remembers when asthma was really considered a psychosomatic disease. These are really, I think, the dark ages of the thinking about asthma. This is something that was in a publication about 2 years ago. In the early 20th century, asthma was really considered a psychosomatic disease, and it represented the suppressed cry of the child or the mother for their help. And we refer to this as sort of the smother-mother relationship of asthma is concerned. And people really focused on this considerably. And psychiatrists took over the care of many patients with asthma. And many of them, a number of them, were dying in the office of patients of psychiatrists because of severe asthma as they were going through their psychological maneuvers. And the consequences, as they said here, were really quite devastating. And we really had the psychosomatic group over here and the physicians taking care of physical medicine. And it was a huge schism. And asthma, I think, got caught in the middle at that time. The concept of asthma as a psychosomatic disease has, I think, fortunately shifted. And it's really shifting towards the bidirectionality between the lung to the brain and the brain to the lung. And I'll go over some of the data to indicate that there are connections. The afferent connection from the lung to the brain is the easiest to show, but the brain to the lung is another one that is more difficult to do. So while all this was going on, almost 30 years ago, the NIH had a workshop, stress and asthma, and we wanted to re-examine the role of and contribution of stress and asthma. There were those of us from the respiratory community, and there were the psychoneuroimmunologists. And I must say, those of us in the respiratory area were a little snarky. And we thought we're going to show the psychoneuroimmunologists the thing about science. It was the flip. These people were wonderful, scientists. And I think they opened our vista of the complexity of studying the brain and trying to put things together. And it was our responsibility to sort of interdigitating with them and find out how things are going on. So this introduced the concept that stress can really modulate connections between the central nervous system and the immune response. And what happened about this time is people said, it's time we put the brain back in diseases rather than looking at it as sequestered over here and totally unrelated. And again, opening up how central nervous system, immune responses, and some of the mediators, such as cytokines, can be affecting both processes. We know that stress can increase susceptibility for viral respiratory infections. We also know that stress can lead to asthma exacerbations. And there are really multiple and evolving pathways through the central nervous system, the neuroendocrine system, the immune system, by which these interactions just begun to look at this. And I'm going to go over some of this information for you. Again, so why has this shift towards insight to interactions between asthma and resulting brain health become important? Well, I think first of all, we know that there are significant associations between stress, psychopathology, and asthma. Depression and anxiety are very frequent in asthma. And I think we tend to think about the fact that this may be the consequence of difficulty breathing. And it may not necessarily be a direct communication just between the presence of the disease and these manifestations. We know that chronic stress, which is very different than acute stress, is a risk factor for asthma exacerbations. And chronic stress actually produces a T2 pattern of inflammation, which again, I think is important to understand. So these are two things that can be amplifying yourself. You've got T2 inflammation in asthma, and you've got something that can enhance it, which is related to another exposure factor, in this case, chronic or stress or chronic stress. And anxiety and depression really are considered treatable traits. And we'll come back to this in a while, that there's interest that asthma, when we take care of the disease, we not only need to look at airway function, but we need to look at factors that are affecting allergies, but also some of the examples of anxiety and depression. And really, I'll show you data that asthma is really emerging, as are other systemic or our other inflammatory diseases, as a risk factor for dementia and also the development of Alzheimer's disease. So first of all, how does stress contribute and influence inflammatory response? This is a study we did over 20 years ago. I got involved with a group of neuroscientists at the University of Wisconsin. One of the first studies we did was, how can we design a study to find out if stress has an influence on the inflammatory response? So we recruited a number of students at the University of Wisconsin, and we studied them baseline during a low stress period, which was the middle of the semester, and then right after their final examination. And what we requested, and again, they were all allegedly very compliant, we said, when you finish your exam, don't go to the pubs and have beer or anything. You report the next day to the laboratory, we'll do a challenge. So what we did is we brought people in, studied them stress, low stress, stress period of time, had a washout period of time of at least 2 weeks. And what we did was look at the effect of the final examination on some of their allergic responses in the airway to an allergen challenge. Well, first of all, these youngsters had increases of anxiety right around final exam period, and also a feeling of depression. We never went back to ask the question, did their degree of stress and depression have any relationship to their grade points that they got that semester? It would have been interesting. But again, we had documentation that they were stressed at this period of time. We then did an antigen challenge on these individuals. And the open circles here are baseline. And again, here's the white blood cell count, 4 hours or 6 hours after the challenge, the white cell counts go up in sputum, stay up at 24 hours. And the rise is primarily related to the recruitment of eosinophils. So what's happening with this stress is there's a greater inflammatory response as reflected by an increased recruitment of white blood cells to the airway, and that they are predominantly eosinophils. So stress enhanced the inflammatory response to an allergen challenge. We looked at the blood eosinophils, and again, blood eosinophils slightly go up following allergen challenge. What interestingly enough we saw was that their baseline eosinophils went up during the stress period of time, maybe allowing more eosinophils in circulation to then be recruited to the airway when the stimulus came about. And again, as you can see, the eosinophils stay up for a period of time. We then looked at the expression of two cytokines, interferon gamma, representing a T1 cytokine, and IL-5, representing a Th2 cytokine. Numbers at this end are a shift towards Th1, and again, the number down here was a Th2. As you can see, the higher the eosinophil counts, the more they were tending towards T2. So what we were doing was actually shifting the balance towards a greater expression of T2 following the antigen challenge during the stress period of time. So first foray into this was to show that stress could enhance the allergic response. It was manifested by an increased expression of T2, reflected by an increased amount of eosinophils into the airway. So we concluded that stress enhances T2 inflammation, doesn't necessarily cause it, but enhances it, and it promotes airway inflammation and the risk for loss of asthma control if they are exposed to a stimulus. The next study we did was called the brain study, brain responses in asthma, analyzed by imaging of the nervous system. And what we did here was a multi-step processes. We took a number of patients with mild asthma. We challenged them with saline. We then did pulmonary functions. We also did an MRI of their brain in relationship to the saline challenge. And then we repeated 4 hours later. We also did methacholine, looking at contraction of the airway smooth muscle without inflammation. Again, the pulmonary function showing the drop in lung function, and then looking at the brain scan 4 hours later. And the same thing when they got antigen. And we did the brain scan at 4 hours before they had their maximal development of airway inflammation following the allergen challenge. So this is what we found. Again, with saline, nothing happened to the lung function. With methacholine, drop in lung function, return back down. But in the individuals that had asthma, we recruited to having a late phase reaction. They all had the immediate drop, recovery, and starting at about 4 hours, developed a late phase response. So we had the classical development of the late phase inflammatory response following allergen challenge. If we looked at the percentages of eosinophils following saline, following methacholine, there was no rise, but following antigen, there was a rise. The differentiation was that you contracted the airway with methacholine, but you didn't cause inflammation. You gave antigen, contracted the airway, and you also caused an inflammatory response. And then we looked at, as I said, baseline brain scans, looked at brain scans 4 hours later following the allergen challenge, but before they had their late phase response. And then we compared these changes to find out what's happening in their brain in relationship to events that are happening in the lung, or in predictable relationships. In other words, what could be happening to be associated with the likelihood of developing an inflammatory response and also a drop in lung function. And here's looking at the percentage changes in area of the brain, the anterior cingulate cortex. And here is the change in eosinophils, and this is the change in the brain scan. As you can see, the number of subjects that we did were small. There's a very high correlation. The greater the rise in eosinophils in their sputum, the greater the signal we saw in the brain for this area of activation. We then looked at the drop in lung function. And again, the greater the signal in the brain, the greater the drop in lung function. So we had associations that areas of the brain were becoming activated before the drop in lung function and before the eosinophils were recruited to the airway, and they were highly significant. So we could actually pinpoint areas of the brain which were found in association with the development of a response in the lung. And this area, the anterior cingulate, is an area of the brain that is associated with processing pain and also assessing sort of conflicts, trying to maintain homeostasis. And when we looked at the lung function, again, we also found this was related. So this was the eosinophils, and then this was the loss in lung function, the drop in lung function, two different areas. So what we concluded is happening, antigen is introduced, into the lung, stimulates airflow obstruction, allergic inflammation. It signals areas of the brain, the insula, the anterior cervical cortex. And again, what we didn't know from these studies was whether or not these changes in the brain are to enhance the reaction or are down-regulating. We felt that they were primarily there to regulate the development. But again, it was again showing association with events in the lung and changes that occurred in the brain in relationship, quite specific to these changes in asthma.
Sure. Just curious, who funded this research? Which branch of the NIH or the neurologist or the?
Well, actually, Len, it was a very interesting situation. There's a place called the Pfizer Institute in Kalamazoo, Michigan. Walter Pfizer owned the Detroit Tigers. He also owned a whole bunch of radio stations across the country. He made buckets of money. At age 60, he was found to have very severe coronary artery disease. And they said, you have about 6 months to live. And he got turned into power of positive thinking. He sort of became emotionally involved with his health. He died at 95. And he donated buckets of money to the Pfizer Institute, which supports this kind of research. So it was just, this is before the NIH was involved. They do a lot of unusual things, but it's an interesting place. Just as a first time I went there, they have 4 areas in which people stay: spring, summer, fall, and winter. You sign into the registration area, and they take you to your room, and they get to your room and they hug you. I was petrified. Here I am in my room, and this woman is hugging me. I'm from the Midwest. We just don't hug. But anyway, they were very generous with
They're still in operation.
Well, they're still in operation. Yes, right. Mr. Pfizer made a lot of money. He made a lot of money. So anyway, trying to get some. Yes, Steve.
Did you try, for example, duplicating the stimulus, but blocking the lung from responding to see if it was just the signaling that was shared versus the sensation of the lung?
Yeah, Steve, we didn't do that. We didn't do this, and that has to come next. And again, I think at that time we did some studies with inhaled corticosteroids, and it blocks it, but it doesn't block it with some degree of precision. It turns off too many things. But absolutely, that's the next step. So here's UW and UW coming together in this study. So we asked the question: what are the molecular pathways that may link the airway inflammation and asthma to functional changes? And Matt worked along with Melissa Rosenkrantz and the rest of us to do the transcriptomics of this study. So what we were interested in was determining the molecular aspects associated with the allergen challenge, which could then relate to the functional brain changes. And to do this, we did segmental allergen challenges. I think Teal knows about what this is. So what we do is we put a bronchoscope down in the airway, introduce antigen, lavage the lung, and come back 48 hours later, reintroduce the bronchoscope into the same area, lavage the lung, and get the cells that have been recruited. We've got baseline and also the changes that occur with inflammation. And what we did was do a brain scan before we did the segmental allergen challenge, and then repeated it after the challenge, was the bronchoscopy was done, to find out what were the areas of the brain that were associated with the inflammation that developed when we introduced the bronchoscope and the allergen. We wanted to identify what might be some of the molecular signals, not just the eosinophils, but some of the genes that might be upregulated in relationship to these challenges. And then we could link them. What events are occurring, in the airway. Oops. So this is, you're going to have to ask Matt what this means. Okay. But what it tells you is that there are a lot of genes that are turned on in relationship to the allergen challenge. just point out a few of these. We did protein IL-17 was identified. We found a receptor for the tyrosine kinase, and we also found Notch and VEGF. These were the dominant genes that were activated in relationship to the allergen challenge. So looking here, you can see a whole bunch of genes that are activated. But then when we looked at some of these in relationships to changes in the brain scan, we found that, first of all, here's these are BL eosinophils, they go up, and it also goes up in relationship to to the challenge. And again, the same thing happens when we measure for IL-17A. So eosinophils and IL-17 are increased. Then when we looked at these changes in relationship to areas of the brain that were activated, and these are areas of the brain that are activated, as you can see, as the eosinophils go up, areas of the brain are activated, and they also go up in relationship to IL. And the genes regulating eosinophils are not necessarily the IL-5 that one would think about. There are other genes that are associated with it. So now we had some evidence to suggest that changes in the airway, at least looking at some of the genes that are present in the cells recruited to the airway, can be identified in relationship, not cause, but in relationship to events of the brain that are activated in relationship to the lung responses that occurred. So it is associated with activation of the brain or some of the neural circuits. And these are circuits that are very important in modifying behavior and also trying to maintain homeostasis. Remember, we're put together to try to maintain stability. We try to recover, and these are things that happen there. And the key molecules included IL-17, which is associated with T2 low inflammation. It's also associated with corticosteroid resistance, and IL-17 is also associated with depression. If you measure this or you put IL-17 into mice, they become depressed. So
How do you know that?
how do we, how do you know that?
How do you know that?
Or we read it in the good book. No, it's well described to be one of the cytokines that does regulate depression, which is really quite interesting.
Interview the mice.
Well, I think even in some human studies. So how does this translate into dementia? Well, so going to this way, here's our hypothesis. You got the brain, you got the lung. Challenge the lung, you set up this inflammation with pro-inflammatory cytokines. It signals the lung, possibly through the vagus nerve, through irritating fibers and sensory fibers in the airway, or it enters into circulation. And then possibly via the efferent vagus, one can then change the events that are occurring in the lung. So again, we thought that this could, if it goes on long enough, it could set up neuroinflammation and neurodegeneration. Again, through Kim, put some from Matt's lab, put the following studies together. So antigen, it acts through the dendritic cells, activates the T cells. You get a T2 pattern of inflammation. And you also get IL-17. So you've got both eosinophils and neutrophils occurring in the lung. And what may be happening in the brain is the following. VEGF is interfering with permeability, opening up the blood-brain barrier, leads for some of these particles or factors to enter into the airway, activates microglial cells, which are like macrophages. If microglial cells are activated along with Notch1, again, they undergo differentiation, they become macrophages, and they set up an inflammation, and if it goes on long enough, it can lead to neurodegeneration. This is theory. This is theory. So this is what we're thinking is happening. And these are some of the molecules I think that are important in generating the response and trying to explain what's happening here
You're frozen.
Hammer, local inflammation. Having identified all these factors that led to inflammation, and it's filled a tremendous gap in our understanding of asthma. We forgot these other things. Now we're getting to a point, and not share your screen about other participants are sharing.
I agree that like the sensory neuropeptides is something that looks so promising and people kind of dropped it.
Right. Right.
Yeah.
I don't think leaving is gonna help. We just need the other person to stop sharing. Are we the host?
There are these studies in the eosinophils will have like data
Psychological.
Oh. I don't know how to sign in. Oh, wait.
Zoom
Yeah.
window open already. They probably should show you.
No, the Zoom cache.
Oh. Must be sharing it.
To open it. Well, it says my body kind of.
That's the biggest.
Yeah. Yeah, well, I was in the process of that, and then everybody started screaming at me to claim host. There was like too many inputs. at once.
So you have me talk.
Yeah.
Anytime. Yeah.
We're not hosts, so we can't. Can some.
No, it doesn't.
And then if you are able to log into your UW, you should be able to claim host as well. Okay, I think it stopped. I think it stopped. Oh, no, it's still. Yeah. Oh, it's not typing.
Up by being the host.
Well, I think he's sharing his screen somehow. I don't know.
I don't even know
why
how
that happened.
Yeah.
Okay, so I think now we should be able to claim those. Oh, he's calling something.
Just close this off completely. I'm just gonna close the Zoom. I don't know. I'm gonna leave. What do you think?
Trying their screen.
Oh, wait, does it stop share up there now? Oh, no, it's him trying. I think that's him trying.
Okay.
We're just talking leave and come back on. Okay.
All right.
Oh my God.
There.
Yeah.
Thank you for Busse. I can try again. Sorry about that. Oh, yeah.
Okay, we're back. Well, thank you all. I think that gave everybody a chance to sort of me a chance to get organized here. So again, repetitive episodes seem to increase the risk for, oh boy, we're not going forward. Pardon?
Yeah, maybe use.
A little lower, and then I think you should be able to click now. Wouldn't be true.
Oh, thank you. Okay, so exacerbations make it worse. So this is another study, longitudinal study out of Taiwan. 11,000 patients with asthma, greater than 45 years of age, 44,000 controls. And they enrolled them from 1998 to 2008. And then they assessed in 2000. Here's what they found. This is looking at the risk for dementia in patients with asthma. Under 65, greater than 65. The risk was greater at the younger group because, again, they couldn't necessarily separate just aging dementia. Also, depressive disorders are risk for dementia. And again, more so in the younger age group. Diabetes, which one they would expect because vascular situations, and cerebral vascular disease. So the data, at least out of Taiwan, is suggesting that if you have asthma, you are at increased risk for having dementia. We looked at the Medicare database, one of the Christy Bartles at the University of Wisconsin, and they asked two questions. One, the incidence of Alzheimer's disease, that is what's happening during this period of time that you're looking at it, or ever Alzheimer's disease in asthma versus control groups. And what Christy found was that, compared to, and again, it's 5 million people. So it's not a trivial number of individuals. Again, the risk factor for Alzheimer's disease incidence with asthma is 20% increased, ever Alzheimer's about 48%. And the same thing with dementia. So looking at a large scale group, again, of older individuals who would be at risk for Alzheimer's disease, asthma is a risk factor. So is rheumatoid arthritis, so is inflammatory bowel disease. But peripheral inflammation is a risk for developing Alzheimer's disease. Now, we also did a study, like I said, we've been working with neuroscientists. We've been doing a lot of MRI scans in patients with asthma. And we did some neuroimaging and biomarker assessments in patients with asthma, varying degrees of severity, and a controlled group. So, as I said, the epidemiological data suggests that asthma is a risk for dementia. We looked at brain structure in asthma, 111 versus 133 healthy controls. We also measured serological tests, which are found in association with the development of asthma. We looked at p-tau 180, which is very specific for Alzheimer's disease. We looked for NFL, which is neurofilament light chain, which indicates neurodegeneration. And then we look for GFAP, which indicates microglial activations. These are markers, serological markers, which are associated with changes with these levels of dementia. So these are brain scans. And again, what they indicate is the higher the number, there's a greater loss of white matter and there's greater diffusion. And again, if you have asthma, there's greater diffusion, greater loss of white matter in your brain. If we look at this in relationship to asthma severity, as asthma severity increases, this loss of white matter is also greater. So functional changes noted on the structure related to asthma, related to the severity of the disease. And then we looked at these biomarkers. And again, the greater the expression of GFAP, and the greater the expression of the neutrophil filament light chains, the greater the loss of brain function. And these have specificity for neurodegeneration and microglia activation. So we have serological markers match up with what we see, in the brain. So it suggests looking, and the interesting thing was that none of these people that we'd studied had cognitive differentials as far as deficits that we could pick up. Again, they were normal functioning individuals. And it raises the question, are these individuals at risk for later development of loss of cognitive function and going on to Alzheimer's disease? Alzheimer's disease is only one factor that can be associated with dementia. There's dementia from vascular changes, from hypoxia, from metabolic changes, and Alzheimer's is one in which there seems to be an abnormality in these amyloid plaque depositions. So the question comes up, is asthma a systemic disease? Michael Peters, when he was at the University of California in San Francisco, looked at the relationship of plasma IL-6 in relationship to metabolic dysfunction and asthma severity. And this was published in Lancet Respiratory Medicine about almost 6 years ago. Non-severe asthma, severe asthma through the SARP program, severe asthma research program, and they centered analysis on associations with plasma IL-6 and their concentrations in the relationship to comorbid, diseases. And what they found is that, as the BMI increased, IL-6 levels increased. And again, if they looked at this in relationship to a history of hypertension, they looked at, they looked at this in relationship to hypertension, it's increased. They looked at it in relation to metabolic function, it increases. In other words, asthma with increased levels of IL-6 is associated with other coexisting diseases, hypertension, metabolic dysfunctions. That's evidence from there. So what Álvaro Agustí and his colleagues in Barcelona looked at was looking at reductions, targeting reductions in asthma exacerbations and loss of accentuated progressive trajectory loss of lung function as far as, association with asthma. And what Álvaro did was looking at changes in lung function early in adult life and how they may relate to later deficits in health. And this was published in Lancet Respiratory Medicine. So his hypothesis was that low lung function, which he said arbitrarily was an FEV1 of less than 80% predicted in early adult life, is associated with a higher prevalence and increased incidence of both respiratory, as you'd expect, cardiovascular and metabolic dysfunctions, and also premature death. And he looked at large databases, Framingham studies, Cardia, and the Gen Hill studies. And I'll just focus on this one over here. So these are individuals that had normal lung function, low lung function, and this is the percentage of anybody having abnormal respiratory diseases, about a 4-fold increase. You'd expect it. The lung function is down, respiratory diseases are common. Cardiovascular disease is increased, and also there's a tendency towards metabolic diseases. So again, low lung function, a reflection of lung disease is associated with cardiovascular disease. So what treatment approaches may be affecting some of these adverse effects of asthma on brain health? Well, there's a concept very popular in Europe looking at treatable traits. In other words, when you take care of patients with asthma, you identify what characteristic they have that may be associated with their disease. Is it low lung function? Is it other aspects, frequency of infection? Or is it anxiety and depression? And so they're saying guidelines are one size fits all. And again, we need to look at factors in the patient, which is making the disease better. And again, one size fit all does not explain this as done by the guidelines. So we need to look at asthma phenotypes as they're influenced by multiple traits that contribute to their lack of disease control. And if you can identify those traits, specifically treat the traits, you might contribute to better control and reduce the severity of the disease. And they have a number of treatable traits. And one of them is lifestyle, which is anxiety and depression. And to do that, we participated in the following study in which we looked at training for mindfulness. There are neuropsychiatrists, a psychologist at Wisconsin, Richie Davidson, has got this mindfulness behavior modification program. And we asked the question is, if we would train people in mindfulness, would this have some effect on asthma control? So as I mentioned, psychological stress and comorbid psychopathology can contribute to lack of asthma control. And we evaluated the training of mindfulness, sort of thinking about yourself, sort of bringing yourself back into a normal sphere could improve asthma control. And what we found looking at the ACQ and looking at markers of depression and also stress, that the markers, the higher the ACQ, the less the asthma control is noted, the higher the stress and depression and stress indices are, the poorer asthma control is. We then subjected them to either non-training in mindfulness or in training in mindfulness. And when they underwent mindfulness training, again, they didn't have bad asthma. Their ACQ scores went down. They felt better. Their asthma symptoms were better controlled if they had mindfulness training. We also looked at it in relationship to their underlying disease process. If they didn't have stress in their life or depression, didn't do anything. But if they did have stress, these are the individuals who, when they underwent mindfulness training, their ACQ improved. So it has some specificity to their underlying psychological, conditions. So what about intervention therapy? This was a paper published about 8 years ago, looking at the treatment for rheumatoid arthritis and risk for Alzheimer's disease. And they, under the same premise in rheumatoid arthritis, feel it's a systemic disease, and it plays a role also in the possibility of making Alzheimer's disease more severe. TNF-alpha, a major factor which can affect brain function, inflammation, and neurodegeneration. And what they wanted to find out was, in treating rheumatoid, first of all, is the risk for Alzheimer's disease higher? Risk for Alzheimer's disease higher in rheumatoid arthritis? And what happens if you treat rheumatoid arthritis with the biologics? May it have any effect on the expression of Alzheimer's disease? Well, the first thing they found was that rheumatoid arthritis increases the risk for Alzheimer's by about 8-fold. Very significant. Biologics for Alzheimer's now have been around for 20 years. So they looked at some of the data and looked at whether various treatments would affect the expression of Alzheimer's in patients with rheumatoid arthritis. Prednisone did nothing, the sulfa derivatives did nothing, but anti-TNF-alpha had an effect. It reduced it. It had some specificity. And the idea behind this was that if you block TNF, you might block its effect not only in the joints, but also in the brain. And what has happened in the 20 years since anti-TNFs have been available, the risk for Alzheimer's disease and rheumatoid arthritis has gone down back to the general public level. So again, it has some profound effects. So, asthma-brain interactions. Challenge the lung, set up an inflammatory response. It signals the brain can respond by becoming more anxious, and also lead to depression if chronic, and also lead possibly to neuroinflammation and also to neurodegeneration. And again, what we'd like to do, and then dementia. So what we would like to do is have greater specificity for identifying the molecules that are associated with injury to the brain and block these. And if we block these, can we then prevent some of these events from occurring in the brain, such as anxiety, depression, neuroinflammation, and neurodegeneration? Asthma is different than rheumatoid arthritis. 10% of the world's population. When does it begin? You're a pediatrician, 6 years of age, right?
I'm not a pediatrician.
No, you're not a pediatrician. Anyway,
But who is?
Steve, no, Steve's an adult medicine. But anyway, that's a rhetorical question.
Okay.
It's a rhetorical question. It starts early in life. It's a lifelong thing. And one wonders, are kids having bad asthma, how well do they function in school? Is this part of the reason that they may have some problems? And again, it goes on for a long period of time. The question would come up, if we can find, and it doesn't appear that inhaled steroids are going to be doing this. This is not going to be affected by that. We no doubt have to have greater precision for bringing these things about. So again, not in my lifetime, but again, the question will come up is if we can treat the primary inflammatory processes in asthma, like they've done in rheumatoid arthritis, like they're doing in lupus, can we affect some of the comorbid conditions, that are found in these diseases? And again, if we do that, even though it may be a small segment of individuals with dementia, the saving is just absolutely immense, because at the present time, there's nothing that you can give patients, you know, for dementia. So asthma affects brain health, anxiety, depression, risk for dementia. We feel that airway inflammation leads to some of these changes. And if it goes on chronically, neuroinflammation, neurodegeneration, and then in some individuals, dementia. And like I said, we're hypothesizing at the present time, if you can regulate some of these patterns in the airway that have some specificity to inflammation, this will then reduce the loss of brain health, including neuroinflammation, neurodegeneration, and even Alzheimer's disease. And the word of the day, folks, is microscope. I have no idea what this has got to do with anything. But anyway, that's the word of the day. So thank you very much for your attention. Thank you for getting me back online. So,
Well, Bill, thanks firstly for putting up all the technical brief and getting through this in such a brilliant way. Then now that we have quite a number of our biologics in our field, similar to TNF or RA, if you had to speculate what's going to be the best one, or what molecule do we want to intercept most to interfere with this process, what would you predict?
I don't know that's the right question to ask. And I don't know the answer to this. And I think what's going to happen is that there may not be the right one for all. And I think we have to get precision on what is happening in Mrs. Smith, Mr. Jones, in other words, what's doing it in them, and finding out the molecule that is doing it and blocking that pathway. It may be eosinophil related, it may be, you know, some of the alarmas, and it may be, you know, some of the epithelial type factors. I don't think we know that at the present time then. But again, that's the next step. And the real question is, when would you have to start? And again, I think some modeling of this could be very important. Again, through the inner city stuff that we've been working on. When kids go back to school, particularly those, you know, in the urban areas, they don't do well in school. Their allergies are kicked up, their asthma's kicked up when they go back to school. And you wonder if you can block the severity of their asthma, would you improve their school performance? Again, we did some of these studies when we gave omalizumab, you know, and treating kids before. We never had the forethought to necessarily measure their brain functions or do brain scans. So I think what we need to do is go back and look at these linkages, find out what's going on. So I think, first of all, getting the brain back in asthma, I think, has been a step forward. And for me, working with the neurosciences has just been absolutely fascinating. I mean, we know so little bit about the brain, and we can't biopsy the brain like we can the lower airway, but some of these imaging techniques really, really sensitive and strong. Matt?
I think that becomes a relevant question, you know, since this is such a disease of pediatrics, that again, how to measure this, you know, you can't just wait for dementia.
Right.
We're actively pursuing this actually CEDA study, which you have on those calls, but what are the right metrics to assess kids? Maybe you can do a brain scan, but probably not repeatedly.
Well, actually, these are MRIs. So
Yeah,
you don't.
I know.
Very right.
So, you know, I know you anxiety, depression,
Right.
scores, but are there other things that are being assessed in young children that look at the neurocognitive outcome in a way?
I don't know the answer to that, Matt, but I think the neuroscientists certainly have ways of measuring kids' performances. And again, you wonder how fluid these are, if they go up and they go down, depending upon the circumstance that's involved. And if you look at, you know, anxiety, and first of all, if you look at, if mother has, you know, depression and anxiety, the kid has got an increased risk for having asthma. And you wonder if this is being transmitted, you know, like an epigenetic, you know, phenomenon. And again, finding out what other factors can be associated. Matt, there's got to be tools for doing this.
Does the association with asthma and dementia hold up?
Good question. I think we looked at this very indirectly, Steve. And again, the more severe the disease, the more likely it is to be associated. And again, you wonder with the milder disease. In some of the studies out of, you know, Taiwan, they had mild disease. They had mild disease. And you wonder about how sensitive were these markers for dementia? Were they looking at very small changes? Or are they looking for changes that could be clinically relevant? Don't know the answer to this. Don't know the answer to this.
Fascinating, because.
Right.
I'm in the older generation, this room, and we did learn when taking care of asthma, go down the checklist of exacerbating factors, rhinitis, et cetera.
Yeah,
Anxiety, depression we think of that more as a result of asthma.
Correct.
And so I think this is a compelling argument to bring that closer to not necessarily disease modifying, but at least
disease influencing.
disease influence.
Right. I mean,
Which is fantastic.
because when I went through training, I mean, we were so turned off by the focus on psychosomatic that was we said, this is not what we want to, tie our heart to. And we went away from it. And as was mentioning, there's neuropeptides out there now. They're there for a reason. And I mean, the communication, is very, very, very important. And I thought it was really exciting, and disturbing. 300 million people have asthma around the world. That's a lot. That's a lot. When you look at the social economic consequences of dementia, it's profound.
And 80 years ago, they weren't that many.
There wasn't as many.
Right.
Right,
So
right,
that's
right,
not looking good.
right, right. Or an opportunity. Matt?
Well, based on the time course of the experiments we've run, you had different time points, 4 hours and 4 hours. You think it's more likely that the circulation based, immune cells migrating to the brain, or is it actually, nerve?
I think it's both. One of the former faculty, Zin's son, who was at Madison at the University of California, San Diego, and Zin has developed a mouse model in which she does repetitive challenges. And one of the things she's looking at is changes in airway hyperreactivity in the mouse model. She submitted her data, and she has found that with repetitive antigen challenge in the mouse, she's actually increasing the number of neurons in the brainstem of the mouse. And it is these neurons in the brainstem that are expanding that are translating into airway hyperresponsiveness. So the question comes up about it's no doubt a circulatory process that gets to the brain, but it may be influencing actually the cells in the brain, which have some specificity for altered airway wave function, which I think, and again, the question is that going to be permanent?
Well, right. It's really
Right. So again, there are now becoming real anatomical connections.
I was curious about the lung function, the study from Spain, so early lung function. So we know that early lung function, like the peak lung function, is related to race, which is very collinear with a whole lot of social determinants of health, right? So because really, once you reach peak lung function, the decline in lung function with age is about the same,
right,
in different groups. And so I don't know, these social determinants of health must also be prominent both with dementia.
Right. Who's at greatest risk for dementia? Women, African Americans, the Dominican Hispanics.
Yeah.
Amy Kind at our place has put together the geographical locations of determinants of health. And again, we find that these are situated. Putting this together, it's the same profile as bad asthma. It's the same profile as bad asthma.
Yeah.
Appreciate it.
Okay. Thank you for breakfast.
Thank you for coming.
Well, we'll have to have you back sooner. 2009